Katie Gutiérrez is the Tax, Budget, and Economic Development Reform Director at Think New Mexico, a results-oriented think tank whose mission is to improve the lives of all New Mexicans. Katie is from San Antonio, New Mexico. She is currently a PhD candidate in economics at the University of New Mexico, a Robert Wood Johnson Health Policy Research Fellow alumna, and most recently taught economics at Williams College in Massachusetts. So with that, go ahead, Katie, and take it away.
Hi, thank you, Amanda. Thank you all for having us here today. We're really excited to talk to providers and people who are on the ground and sort of talk about what our legislative priorities are this session, what's going on in the legislature, what might be hot button topics, and then at the end, what you all can do to get involved. So hopefully this is a productive conversation, and I will save a little bit of time at the end so that we can have some Q&A, because we have quite a long and comprehensive agenda for this session in terms of healthcare, and a lot of it relates either very directly or indirectly to primary care. Um, so with that, I know there's some gray boxes on my screen. We were having some technical difficulty with screen sharing, so hopefully they don't block too much of my slides here. So my name is Katie Gutierrez. As Amanda said, thanks for introducing me, Amanda. I am Think New Mexico's Tax, Budget, and Economic Development Reform Director, which is a very long title. I usually say that I am the economist here at Think New Mexico. I'm trained as an economist via UNM, and I do health equity work, sort of public health adjacent work in economics. So my dissertation is on grocery taxes and health outcomes. Um, and here at Think New Mexico, I do a lot of economic, statistical, and statutory research on the topics that we are talking about, which for the last 2 years has been the healthcare worker shortage. So that's what I'm here to talk to you about today. So I will start off with a little bit of information about Think New Mexico. So we are a very small group. Our executive director, Fred Nathan, is also our founder. He founded Think New Mexico in 1999 in order to come up with common sense solutions to problems plaguing New Mexico. And we are not a partisan group. This is our board. And so we have Republicans, Democrats, independents on the board, former governors, um, business people, former Supreme Court judges. We have a very wide variety of expertise, not only on our board, but also on our staff. So our goal really is to hear what New Mexicans are saying, people in our communities, people that we reach out to as Think New Mexico, and see, kind of take the pulse and see what issues there are that we could really do some research on to make evidence-based policy recommendations. And our goal is to make these recommendations in a way that benefits all New Mexicans. So we are a staff of 6. We have a healthcare policy fellow. We used to have a healthcare reform director. So now we have a healthcare policy fellow. I am the economist. We have an education reform director. And then we have our associate director and our director, which are Fred Nathan, our executive director, and Christina Fisher, our associate director. And so we're a very small team, so we try and focus each legislative session we try to focus our efforts in a very concerted way in order to most effectively advocate for New Mexico and the particular issue that we are working on that session or over the last few years. So in 2024, we published this report, which is How to Solve New Mexico's Healthcare Worker Shortage. So the year before that, we had done education. This last year in 2024, last legislative year, we focused on healthcare. And those two things are so big in New Mexico, right? Like such wide and far-reaching issues that this year we actually didn't publish a new report. We continued to work on education and we continued our healthcare worker shortage efforts. So that's what I'm going to be talking to you about today is that healthcare worker shortage report, our recommendations from this 2024 report and all of the research we did, and then what we are looking forward to this legislative session. So as I think some of this will be a little bit preaching to the choir in terms of talking to you all as primary care providers or people in the primary care healthcare network. But New Mexico has lost 248 doctors since 2019. This is 8.1% of our physician workforce, which is staggering. And this is from the Physicians Advocacy Institute. Of the states that they looked at, we were the only one to lose doctors. And actually, nationally, there has been a slight increase in the number of doctors actively practicing. And as you all know, most of our counties are healthcare professional shortage areas, whether that is because they have a vulnerable population, because they are particularly rural, or just the per capita physician to population ratio. Los Alamos is actually the only county that is not technically a health professional shortage area. We also have a little bit of a unique physician workforce in terms of demographics. A large proportion of our physicians are getting near to retirement. And so that is particularly concerning, especially because we have such a vulnerable population group in New Mexico, right? Patient population in New Mexico. 43% of New Mexicans are on Medicaid. We have an aging population. New Mexicans are more likely due to structural issues to have chronic conditions, right, than the national average. And in order to just maintain the status quo, so what we have right now, the condition we have right now, which we are already in a shortage, New Mexico will require an additional 2,100 physicians over the next few years. And that's because a lot of these physicians who are older will retire, and some, as we are about to talk about, will actually leave the state to practice elsewhere. And this healthcare shortage, of course, I'm an economist, so I want to know how much this will cost, but you can think of this cost as sort of a ripple effect, right? So like I calculated that this shortage is costing, and not just of physicians, of nurse practitioners, of PAs, of OTs, of all of the allied healthcare professionals, of EMS, is going to cost the state $1.4 billion a year, which is about 10% of our state's budget. And this isn't just in lost tax revenue. This is the effect of a physician not, for example, a physician, I'll just take that example, not working here. So they are not, right, like hiring support staff, or even if not directly hiring, their company is not hiring support staff to assist them. They are not contributing to the healthcare economy. The patients who would have gone to see them will either have to wait to see another provider. Acute conditions can turn into chronic conditions for those patients. Chronic conditions can worsen or go untreated. That's a pretty comprehensive number. And so we estimate that it costs $1.4 billion a year just to put all of these shortage numbers sort of into a price. As for our legislative agenda here at Think New Mexico this year, we have 5 major goals. So you have probably heard rumblings of some of these if you are tied into the policy landscape. Our first is to enact medical malpractice reform. We also want to get rid of the gross receipts tax, or the GRT, on coinsurance for medical services. And I will go through all of these in more detail in the next few slides. We want to increase funding, so find new funding sources for the Medicaid Trust Fund that was created in the 2025 legislative session. We want to expand student loan repayment. There already is a program, but we want to expand it, add more money, and increase who can get it and how much they can get, specifically for healthcare providers, since we know that so many of you all have a lot of student debt. And last but not least, we want to join all 10 of the major interstate healthcare worker compacts. We are currently in the nursing compact, but there are 9 other ones that we could really benefit from joining. So I'm actually going to start with the 10 interstate healthcare licensure compacts. This is very, I think, relevant to primary care physicians. Um, so in terms of these compacts, what they do is they work pretty much like a driver's license works. So, for example, I have a driver's license in New Mexico, and again, I'm probably preaching to the choir. You all probably know this, but if this is going up on the website, hopefully it can help educate people who are not quite as in the weeds as you all are with the licensure process. So these work like driver's licenses. I have a New Mexico driver's license, but I am allowed to drive in Colorado. So Colorado, recognizes my New Mexico driver's license and trusts that New Mexico has vetted me sufficiently to be able to drive anywhere in the US, not just Colorado, any other state. This is similar to how the interstate healthcare licensure compacts work. It allows providers to practice in other member states without going through each licensure process individually. States still have complete jurisdiction within their borders. So, say a Texas physician provides telehealth to a patient in New Mexico. New Mexico has jurisdiction over the care that occurred to that New Mexico patient while the patient was in New Mexico. So there's really no issues about, state sovereignty with these. These compacts usually we see in the literature result in a 10 or 15% increase in providers annually. This is due to it just makes it much easier to cross state lines to practice medicine, right? So if you live in Durango, you could come down to Farmington a few days a week and practice medicine much more easily than if you had to go through the entire New Mexico process in addition to already having your Colorado license to practice. So this would impact telehealth, particularly travel healthcare, and it would allow New Mexicans to see out of state specialists. A close friend of mine was going to the Mayo Clinic for some treatment, and they couldn't they couldn't do telehealth. The provider was not willing and could not practice without a license, of course, in New Mexico. So she had to drive over the border into Arizona every time she needed to have a telehealth call with her physician. And so this is really causing a lot of not only material hardship, but also financial, mental hardship for patients having to travel to get healthcare. And no state has ever left a compact. And as you can see on the right, there are many, many states in these compacts. The Interstate Medical Licensure Compact, which is for physicians, has 42 member states. The ones at the bottom, the PA licensure and the dentist and dental hygienist, have fewer, but they were founded very, very recently and are not even active yet. So we have a few bill numbers for these. And so we have one Senate bill, which is the medical licensure compact, and then we have a few of the other specialty compacts that are in the House. So you can go onto the website and see those. And once we get more bill numbers, we will update our website as they come through. We're in the pre-filing phase now, so we're just seeing them as they come in. So we don't have all the numbers yet. One of the other major issues that we're working on this session is medical malpractice. This is probably what you've heard about the most in the news recently if you've been watching this. So New Mexico really is an outlier in a lot of ways in terms of our medical malpractice environment. We have the most medical malpractice payments per capita of any state. And right, we don't believe that providers in New Mexico are committing malpractice, acting outside of the standard of care at any rate higher than any other state. We believe New Mexico's providers are just as high of quality as those in other states, and yet we still have a really large number of medical malpractice payments per capita. Because of this, and for some other reasons, which I will get into in the next few slides, our medical malpractice liability insurance is much more expensive here. I'm sure possibly some of you primary care folks have experienced this, and I only have numbers here for OB liability insurance, but the pattern holds that New Mexico's liability insurance rates are much, much higher than those in surrounding or peer states. So you can see it's $102,000 for a New Mexico independent OBGYN, whereas you could go across the border and practice in Arizona for half that, less than half of that per year. And it is not right because New Mexico OBGYNs are particularly risky for any reason. It is the medical malpractice law environment here. So not only is liability insurance more costly here, but the insurance companies are still losing more on med mal payments than they are getting in premiums. So even though they are charging more here, they are also losing more money here. The good thing is that we can look to other states and see that a lot of other states have enacted several different reforms that really seem to provide guardrails on this system to make it so that patients who are injured by someone practicing outside the standard of care are able to be compensated for that and made whole, while at the same time we are not threatening providers' personal assets, small practices' ability to stay in business, etc. So I will explain a little bit of that in the next few slides. Of course, this is a major issue that we are hearing from providers. This is a major way that particularly independent providers are feeling the squeeze. And one more thing that is making it more financially difficult to practice at all in New Mexico, but particularly as an independent provider or someone working at a small clinic. So even if you are not paying, you're not an independent provider and you're not paying the malpractice liability insurance yourself, it does affect the bottom line of even larger healthcare facilities like hospitals. In terms of public health, again, preaching to the choir, but just this lack of access, if we are losing hemorrhaging providers due to the medical malpractice environment in New Mexico, along with some of these other things. But this is the number one thing we are hearing from people. This lack of access to primary care leads to a lack of access to specialists because there's just fewer referrals. There are fewer specialists as well to begin with. And this all causes just massive downstream public health effects. Acute conditions can progress into emergencies or into chronic conditions. Chronic conditions can go undiagnosed and untreated, and overall population health just really suffers. And so when we're thinking about this, we are asking doctors and other healthcare providers, why are you leaving? They are all saying medical malpractice. So we have 8 major proposals. I will go through the main ones that we are expecting to see in bills this session. But this is a more comprehensive list, and you can find all of these and a much longer description of and discussion of these in our healthcare report. So we want to raise the burden of proof for punitive damages. This is one we expect to see this session, so I'll go into that in another slide. We also want to cap or in some way limit punitive damages. There have been several high-profile punitive damages awards in the last few years in New Mexico, including one that threatened to shut down Gallup-McKinley Hospital, which would take away healthcare from the tens of thousands of people in the Gallup and Grants area that really have no other recourse in the area. We recommend ending venue shopping, which is holding the trial for the medical malpractice incident in a county or a locale other than where the injury happened. Preventing stacking is another one of our policy recommendations. Stacking is what we call it when, say, something happens in the OR. So multiple people were involved in the process, in the documentation, in the decisions being made of what led to malpractice. Right now in New Mexico, you can sue for each one of those mistakes or each one of those providers that made a mistake. And we are hearing from insurance companies and from healthcare providers that that is an issue contributing to the high risk of medical malpractice lawsuits. The high threat of punitives makes providers want to sue. That's another one that I will talk about in more detail. Right now, the Patient Compensation Fund is it pays for future medicals. So as you accrue future medicals, that pays out not in lump sum, but one future medical payment at a time as they occur. But the original payment that you get in your medical malpractice settlement or when the jury decides on a payout, that is in a lump sum. And so it leaves patients sort of unable to anticipate and manage their not only their future medicals, but other costs and things that arise during the medical malpractice trial. Require truth and damages, which is not just for the PCF to pay out for the amount that the insurance company bills, right? But actually the amount that ends up being paid by what would have been paid by the insurance company. We recommend that the state enact a full apology law, which just provides language making it so that if a mistake occurs or even a bad outcome, not necessarily malpractice, if that occurs, the provider can feel free to apologize or speak about the incident without worrying that that will be held against them in a court of law if the case becomes a medical malpractice lawsuit. And our final recommendation is to cap attorneys' fees. So attorneys take a cut of what the victim of malpractice is awarded, and it can often be a significant portion of what they're awarded. And when these funds are paid to make the victim of malpractice whole, the attorney is cutting into that quite a bit. So we would want to rein that in. That's one of our recommendations. So I'll talk about the three, I think, or four major parts of this that we think we might see this upcoming legislative session. Again, these bills haven't been pre-filed, and although we are advocates and we talk to a lot of legislators about what kind of bill they might write and what they think they might include, nothing is for sure until it's pre-filed. And even then, of course, it can be amended and we'll go through several committees as the law is being made. So as of right now, we are not sure what any med mal bill will have, although we think there may be more than one. So I'm going to tell you about some of the things that we think might show up in some of these bills, and also some of the things that we think might be important. So punitive damages, in terms of this, punitive damages are awarded when there has been egregious harm. So, for example, when someone acted with the intent to injure another person. So New Mexico right now has the lowest burden of proof, which is a preponderance of the evidence, which is just like if a little bit more than half of the evidence shows that there was some egregious harm done, then you can, the jury can award a punitive award. Other states have higher burdens of proof. We recommend clear and convincing evidence, although Colorado does recommend beyond a reasonable doubt, which is the criminal standard. Medical malpractice is not criminal, it is civil, but Colorado has a very high standard of proof for punitive damages in medical malpractice. We recommend coming in line with other states and going to a preponderance of the clear and convincing evidence. 33 states, as you can see from this map, require a higher burden of proof than us, and actually 6 states do not even allow punitive damages. And so this, right, the threat of punitive damages, if you are faced with malpractice as a provider, a malpractice lawsuit, and you are looking at, okay, well, I have to pay compensatory, which is lost wages, maybe something for pain and suffering. And then on top of that, in New Mexico, it's very easy for a jury to award punitive damages because they only need to prove a preponderance of the evidence. that makes your risk of losing a lot of money, right, in the settlement or in the payout very high, which even though medical malpractice liability insurance doesn't cover punitive damages, this threat of punitive damages does make physicians and their lawyers more likely to settle, or other providers, not always physicians, more likely to settle, which costs insurance companies more. And the idea that you could get punitive damages is also, right, like an incentive to sue. And so this all creates a risky environment to not only practice medicine and to try to provide care, but also creates a risky environment to provide medical malpractice liability insurance. So this is part of the reason that we see rates that are so high. Another portion of punitive damages is not only so like at what legal standard should we award punitive damages, but should we limit them at all? So right now, New Mexico has no limits on punitive damages. There have been some staggering ones in the news lately. 42 million. There was a 90 something million a few months ago. And this is right, like that is an exorbitant amount of money. And so, like I said, it just incentivizes defendants to settle. And it's very, very easy for juries to award these, which makes sense, right? You see someone who has been injured and you as a juror feel bad, and there's very few guardrails. So it makes sense that this is just the logical outcome of a system that we have that is very unbalanced. So our first recommendation, and one of the options that we have and that many other states have actually taken in terms of punitive damages, is to put a cap on them. So just say you cannot award more than 3 times the compensatory damage amount, or you cannot award in punitive damages more than $10 million. It varies a lot by state, but you can see here that 27 other states limit punitive damages in some way. Some of them don't allow punitive damages to be awarded. Some of them have a cap. Some of them actually send some of the punitive damages awarded to a patient safety fund to try to just reduce patient harm in general. One other thing with capping punitive damages is we would want to have no personal liability for providers. So that, right, if you get sued, you aren't looking at losing, for example, your home, or you don't have to declare bankruptcy in order to protect your personal assets. One of the other issues that we would like to see is in New Mexico, we see a lot of venue shopping. So, for example, if a medical malpractice incident or alleged medical malpractice happens in Hobbs, very frequently, Hobbs, for example, very frequently these cases will be tried in Albuquerque or Santa Fe, places where juries are known to be more generous, but also are not really a jury of the injured party's peers, right? An injured party's peers live in the area and go to the hospital where that injury occurred, and they have a vested interest in keeping the healthcare system functioning in their area. So we would want to require that cases be brought in the county in which the patient is actually injured. 31 other states restrict venue shopping in some way. Prohibiting stacking is, I explained it a little bit earlier. We would want to define an occurrence of medical malpractice as a single injury equals a single lawsuit. And 21 of 28 states that cap damages prevent stacking. So in New Mexico, we have a compensatory cap, but we don't have a limit on stacking. So what we sometimes see in this is people will sue the provider and the healthcare system that the provider works for example. So you can get the $250,000 from the provider themselves, and then you can sue again for the same injury and get $250,000 from Christus or whatever employer of that provider you filed a second lawsuit against. So that's all for medical malpractice. This is our sort of most contentious issue this session. One other thing, actually, I have one more after this, is to expand the health professional student loan repayment program. There is a program in New Mexico, but it is it is not funded well enough to be able to award all of the applicants. So in fiscal year 2023, only 14% of applicants actually received student loan repayment. That jumped up to 65% in fiscal year 2024 because the legislature funded the program a lot more. We do recommend that this coming session, fund it much more and also increase the amount. And so, in terms of where New Mexico stands, there are 36 states that have more generous student loan repayments programs for healthcare professionals. The most generous states, four of them, offer up to 300,000, and for physicians, the average debt is somewhere around 250,000. So we do recommend bringing it up at least to average debt, and that would put us in a much better competitive spot versus these other neighboring states that people who are looking to practice in the Southwest or in the West might be looking at. Evidence shows actually that student loan repayment is something, right, that providers are looking at when they are looking to relocate maybe after residency or maybe after nursing school. And luckily, our program is it covers a wide number of professions. So not just physicians, but nursing, all types of nursing licensures or degrees, mental health, dental, allied health professionals. And also, as I'm sure you all know, if your loans are repaid, you are free to practice maybe in an HPSA, a healthcare provider shortage area, or a rural area, rather than working in a position where you can crank out your debt and then go do what you really want to do, go serve the population that you really want to serve. And so this is just another way that we could attract and retain providers, retain people not only doing primary care, but all of your colleagues doing specialty care as well. So I've talked to you a little bit about all of these things squeezing providers on like what makes it difficult to be an independent provider financially. One of the things is 43% of New Mexico is enrolled in Medicaid. And as you all know, Medicaid reimbursement rates, one, are much lower than private insurance rates, and two, are going to have to be ratcheted back to match 100% of Medicare reimbursement rates due to the big, beautiful bill, right? A federal law requiring us to sort of ratchet back our provider reimbursements for when they treat Medicaid patients. So what we wanted to do with this was use some of our one-time oil and gas money, or not one-time, but booming oil and gas money that we have right now, and create a permanent fund. So this would grow like a trust fund. So like you have a savings account and you invest it, right? You put it in a brokerage. This fund would grow just like that. And actually, they did create this last year. Senate Bill 88 created the Medicaid Trust Fund, and they funded it to about $511 million over 3 years. This will take a long time to reach the goal of $2 billion. The goal of $2 billion is because when the fund reaches $2 billion, New Mexico gets a federal match of $3 for every $1 that the state spends. So at $2 billion, if we have a 5% draw that we can take out of the fund each year and still let it grow, that will be $100 million that we can take out each year. With the federal match, that makes that 100 million into 400 million annually that we can start to distribute to the healthcare authority so that they can spend it on Medicaid. So as you can probably see from my graph here, 511 million over 3 years is too slow. It is not going to get us to the $2 billion goal that we need to begin to bolster our Medicaid program here in the state with these federal cuts, because program costs are expected to rise with some other federal impacts on Medicaid. Luckily, the fund was really created, the wording of the statute that the fund was created with is really open. So the funds could be used to fill gaps in the current program or to expand the program in some way. We could get this Medicaid money to providers in a way that is not via the direct reimbursement rate. We could be creative with it like that. Also, to the Medicaid program, even right, if you personally do not treat Medicaid patients, a lot of your other colleagues might, and that Medicaid, because it's 43% of New Mexicans are enrolled in it, is a very large part of our just overall broader network of care in New Mexico. And last but not least, we want to reduce and eventually repeal the GRT on medical services. The GRT is sort of like a sales tax in New Mexico. We don't have an excise tax as a sales tax, we have a gross receipts tax. The average rate in New Mexico is a little over 7%, and that's a base state rate, and then counties and municipalities can add their own rates on top of that. One other thing making it hard to make ends meet as a provider, right, is that providers can't pass this tax on to patients. For example, when you go to the hardware store and you buy screws, you pay the tax. The hardware store has passed that tax onto you, the consumer. But this can't happen with the gross receipts tax on medical services, and insurance companies just won't reimburse you for it, right? And in 2023, the legislature actually did do this. They temporarily paused the tax on copays and deductibles. Unfortunately, coinsurance payments, so Medicare, Medicaid coinsurance, was left out of that. And we had a bill to repeal the coinsurance tax in 2025, but it wasn't revenue neutral. There was no real direct way to pay for it, so it was vetoed. But we are going to try for that again this year. So just to wrap things up, in 2025, we had a bill with 12 Republican and 12 Democratic co-sponsors that was about medical malpractice reform. This ended up stalling in Senate Judiciary, but we're hoping to get it through much better this time. There's been a lot of discourse in the last few years that have drummed up a lot of public attention, so I think legislators are feeling the pressure on this. Senate Bill 88, like I said, created the Medicaid Trust Fund and started a really, really good starting point for us to get to a permanent fund that will provide a really long-term revenue stream for Medicaid in the state. Like I said, there was a tax provision reducing the GRT on medical services. It didn't pass, but we are hoping for that this year, and we will be advocating for all these things. And also, 7 of the medical licensure compacts unanimously passed through the House last year. So we're just looking to continue on and improve this progress. So what can you do as either individuals or an organization or organizing yourselves? The first recommendation we have is if you all as a group, as an organization would like to endorse any or all of this legislation, we have a large coalition of groups who support the compacts, who support medical malpractice reform, and you can join us there. You can also visit our website. This is more for you as individuals. You can visit our website, thinknewmexico.org, sign up for our emails, which have a lot of information about what we're doing during the legislative session, where bills are, what committee they're in, what's next for the bills. You can also click on a tab on our website that says Take Action, and we are updating that with new bills soon, but you'll be able to really easily contact your legislators about these issues. And also, if you are really raring at the bit and wanting to get involved in any of these issues, or if you want to talk to us, please reach out to us. You could organize your colleagues to testify for some of these bills. You could write letters to the editor, which we can help facilitate if you would like. We can also help facilitate if you would like to come talk to legislators during the session. It's helpful for them to hear from practitioners, and I know that people are very busy, particularly if you're practicing clinically. So that's another thing that you can do, and we can help facilitate that to save time. And there's more. So you can reach out to us either via our website. We have a contact form. We're at Think New Mexico on all social media. All of our emails are our first name at thinknewmexico.org. So if you want to talk to, for example, if you heard that we also work on education and you want to talk to Mandy Torres, our healthcare or our education reform director, it's just Mandy at thinknewmexico.org. Here's a QR code to our healthcare worker shortage report. And that is all I have for you today. Thank you so much. And I hope that a lot of this was either directly relevant to primary care, and not only that, but also to the broader network of physicians and other health professionals that primary care folks work with and refer to and rely on in our broader healthcare system and care network. So thank you all for having me. And I think that I have a few minutes for questions, maybe about 5 minutes.
Yeah, thank you so much, Katie, for all that information, especially, that short list of what can you do, I think is going to be super helpful. I do see a few people have joined us since the start of the session. So yeah, if anyone has any questions, comments, now would be a good time.
Katie, I have a question if you don't mind. And excuse my ignorance on this. I'm don't know too much about like the budget aspect, but when it comes to the medical malpractice lawsuits, do those affect the state budget here in New Mexico?
That's a great question. So they don't affect the state budget directly. What we do see happen though is the patient compensation fund. So in New Mexico, you have, if you join are a provider that joins the patient compensation fund and sort of gets the benefit of being in there, you have this like base amount of coverage from a private insurance company, and then the patient compensation fund on top of that charges a surcharge and then pays for whatever your insurance doesn't cover up to a certain amount. And so while our medical malpractice insurance, these rates and the amount of lawsuits that we have don't directly affect the state budget, it does affect some part of the state. For example, the patient compensation fund recently had to add on to their surcharge to stay solvent. And so they could ask for an appropriation, or they could just charge providers more, depending on how the patient compensation fund and the office of the superintendent of insurance wants to run it.
Yeah, because one thing I was wondering was just in terms of some of the funding that, if it does affect the state budget, I mean, could some of that funding then be used for something like student loan repayments or like repurposed for something like that, or the Medicaid trust fund to help, grow that?
Yeah, definitely. And there are other ways of dealing with medical malpractice that could take some of the burden off of the state budget. It's not, like I said, it's not quite so direct, but you could imagine, um, right, like some sort of fungibility between all of these things. And I think you're right about that.
Excellent. Thank you.
Katie, thank you so much for your presentation. This was very informative. I'm not a medical provider, I'm not a resident, but I do teach students that are interested in becoming nurses and doctors here in the state of New Mexico at NMSU. I know you were, and forgive me if I didn't quite understand this, but you were talking about generous states and the reimbursement aspect of it for doctors and nurses, if I understood that correctly. As I was listening to you, I was wondering how, especially for nurses, because I know sometimes we often talk about our doctors, but we don't talk about our nurses enough. As you know, and everyone on this call knows, lately the nursing degree is not considered a professional degree anymore. what's the impact of that when it comes to their practice, when it comes to the economic aspect of losing so many of our nurses to that? Because I hear it with our students now. I hear it that it's not worth it to go through the trouble. It's not worth it to go through the stress. How do you see that on the economic side of things?
That is a great question. So, luckily, at the state level, we have the ability to, whether or not nursing is federally considered a federal degree anymore, we do have the ability on the back end to include nursing and other allied health professionals that may no longer be on the professional degree lists, right, in our student loan repayment. The issue that I also think you are partly alluding to is that if students are no longer able to take out loans or to take out, right, loans with lower interest rates because they might be federal loans for those degrees, then this bill in particular will not address that, this policy, but that is a concern, and that is something that I think legislators are thinking about. But you are definitely right that this will help on the back end, but it's not going to help if they can't get those loans in the first place.
Yeah, I just as a follow-up, I mean, a lot of our students are on Pell Grants. A lot of our students are looking to just get through that hurdle of even obtaining a higher degree, let alone something that is so crucial to our states. As you mentioned, I mean, we have 200 plus doctors leaving the state for a variety of reasons. And now with, the federal government considering this profession, especially when it comes to nursing, not being looked at as a professional degree, I'm really concerned of the ripple effect that's going to cause. And also, how is it that those that run these agencies, these, services, etc., how are they prepping for that? Because it's one of the, in my opinion anyway, I know it's a lot to deal with in such a short amount of time, but it's also the reactive versus the proactive, and how are we going to take care of that so that the state continues to receive the care that it needs, and not fumble in everything else that may follow as a result of it.
Yeah, exactly. And I do have some hope for that because we have seen the state reacting fairly quickly, at least to things happening at federal healthcare level. But yeah, there definitely is a concern there. Luckily, the one thing about our student loan repayment program that is kind of nice and will hopefully add some fuel to the fire of people continuing to wanting to get nursing degrees and other professional degrees is that our healthcare provider student loan repayment program is very flexible. So it doesn't matter if it's a federal loan, if it's any sort of subsidized loan, if it's a public school, if it's a private school loan debt, if it's undergrad debt, as long as they have the debt, the program is pretty flexible in what it can pay off. So hopefully that is some, but I definitely agree that there is a need to be proactive in these things, not reactive. Thanks.
Thank you so much.
Any other thoughts, comments, questions at this time? And actually,
oh, go ahead, Amanda.
Go for it, Mark.
Go ahead.
No, I just had a comment because, Katie, like you said, the student loan repayment is such like a great recruitment and retention tool. And I know I personally like have talked about it, but I didn't realize that it wasn't even that competitive, like for our state. So thank you for pointing that out and going in depth details for that, because that is an issue if, once people realize that could affect a lot of people. So yeah, go for it, Mario. Thank you.
Thank you.
Yeah, so I guess another question that I had was just, the way that we look at New Mexico right now is it's a very dire situation. But have you noticed, just in kind of research or anything like that, if there are any other states where, they've been in a similar situation that can serve as a model to like show like, right, hey, if we change medical malpractice and we do this and that, and we change all of these things, like we can see this increase, like look at this state. Do you know of any examples like that?
Yeah, so there are several states that have enacted tort reform, usually in response to medical liability rate crises. The issue is that they do all the tort reform at once. So they prevent stacking and they cap punitives and they do all this. So it's difficult to tease out exactly which one of these is happening. But that said, um, most states, right, have a lot of these and are not in a rate crisis. So while it's difficult to say like before the tort reform this happened and then after this happened, we do see some evidence of states slowing their rate crises as they implement some of this medical malpractice reform. So while I don't have a state off the top of my head, it is evident that at least some of these or some combination of these work. Yeah.
And as a follow-up to that, we had presenters yesterday actually that said that I guess the nursing compact that New Mexico joined, that was in 2003. So,
Yeah.
over 20 years ago. But it's very similar, are there any lessons that can be taken from back then that apply to now potentially?
Yeah, so I think one major thing is we haven't had any issues being in the nursing compact. Another thing is there's some pretty staggering, I don't know off the top of my head, but there are some staggering estimates of how many of the nurses practicing in New Mexico at any given time are actually travel nurses who are here because of the compact, or at least their licensure was facilitated by the compact. And travel nurses, right, and travel healthcare often gets paid more than local permanent healthcare. And so there is a lot of evidence that the joining the nursing compact has not caused any problems here. And in fact, like we've had access to, right, like young, energetic, traveling nurses that are able to come, but also like, for example, nurses who might come with military spouses, nurses who might come to Los Alamos with partners who are also in STEM. And so we do see that this just really like helps people move across state borders. And with nursing, we've been able to see, a lot of nurses here because of the compact. And so we expect the same thing for not only the doctors compact, but all of the other compacts. And it's really important. I recently learned there's travel speech language pathologists or travel audiologists. They do travel healthcare. There's travel PTs, there's travel OTs. And so it's not, we always think, at least I always think of travel nurses. But I think joining the compact is really important for all of these healthcare professions.
Excellent. Thank you.
Yeah, thank you.
Anna Maria in the chat just said, thank you so much. It was really helpful to understand each component of how medical mal impacts us. And then Charity requested a copy of this recording. So there's that. Any other comments at this time? Other than that, thank you guys so much for being here. Katie, thank you so much for all the information. Really appreciate you and your willingness to come speak.
Thanks for having me.
Alrighty, everybody. Thank you so much and have a good rest of your evening.